Good morning, everybody. I'm Catherine Deneux-Tharaux from Paris, France, and I'm leading the French National Confidential Inquiry into Maternal Death. And today I have the pleasure to share with you our results on maternal suicide, which have emerged as a major and largely preventable cause of death. So thanks to the organizer to give me the opportunity to share these results, and in particular to Serena and the ITOS team. And please apologize if you see some mistakes in the Italian of my slides, because I don't speak Italian. So I have the challenge to read Italian, speaking in French, speaking English, and thinking while thinking in French. So this system works as a three steps process. First, we identified all women who died during pregnancy or up to 1 year after its end, and this happens through multiple sources. But most importantly today, I would like to insist on the linkage of birth and death registers that allows to identify all women who died within 1 year after a birth, and this component of the identification is of major importance for suicides analysis, identification, and then analysis. When this multi-source system has identified a death, then for each of them, a pair of clinicians, which we called assessors, go on site, meet the care professionals that have taken charge of the woman, consult all medical documents and everything that can provide information on the case, and then fill in a questionnaire that include closed questions, but also a lot of open questions where they can insert narrative and the way they perceive the story. All this information is then anonymized and reviewed during plenary sessions by the National Expert Committee on Maternal Mortality, and this committee will decide whether the death is a maternal death or not, then assessing the causal relationship with pregnancy. And if it is a maternal death, then we provide a consensual judgment on the quality of care, and if there were suboptimal care, and if yes, in what sector of the management, and also provide an assessment of the probable, possible or not preventability of the death, and if probable, probably or possibly preventable, what were the factors that, if conducted differently, may have prevented the death. So this system has a double objective. First, document the epidemiological profile of maternal mortality in France, but also through this national and we hope exhaustive audit of maternal death, then provide key messages to improve care. So this very classical figure illustrates the philosophy of this inquiry, which is better understand to better prevent, and this involves reconstructing the full trajectory of each woman and looking beyond the immediate medical cause to understand systemic issues. So all reports are freely available online. The last one was launched last year and focused on maternal deaths from 2016 to 2018, and I will now share briefly general results from this report. Then we will focus on the profile of maternal suicide. So before looking at more recent years, we must keep in mind that maternal mortality in France, and I guess that's the same in Italy, was 10 times the current level just after World War II, And because of the immense improvement in obstetrics, in anesthesiology, antibiotics, and multiple domains of medicine, these rates are steadily deeply decreased. But then there is a change in the way the rate evolves, and we have now the feeling that the rate is more or less steady, stable around 10. And that's what we see here with the data from the last report from the ENCNM, our National Confidential Inquiry. You see that for the last report, we had for these 3 years, 2,072 deaths with a maternal mortality ratio almost 12 per 100,000 live births. But of course, this is up to 1 year, and we work on that in France. But for international comparison, where the rate up to 42 days is considered, we see that we are at 8.5. Interestingly, there is no statistically significant evolution over the last 12 years, either when considering the MMR up to 1 year or up to 40 days. So we can say that in France, we have around 90 maternal deaths each year, which means 1 death every 4 days. This absence of decrease can be considered as a bad news, but at the same time, we must keep in mind that the general level of risk of pregnant women is increasing with increasing age, increasing BMI, increasing prevalence of comorbidities in these women, and that the other way of considering this stable rate is to say that despite this increase in risk, the rate remains stable. And the other element is that we, over time and with increasing knowledge of how pregnancy impacts different diseases, there are more and more conditions that are included in maternal mortality that were not before, in particular in indirect maternal death. And suicide, as we'll see just after, is a good example of this. This level is comparable with what is reported by other countries that have such enhanced system. So what about maternal suicide? So just a reminder that the focus on maternal suicide within maternal mortality surveillance came from a recommendation from WHO launched in 2012. WHO recommended to consider all suicide that occurred during pregnancy up to 1 year after its end as a maternal death, not trying to disentangle whether pregnancy has played a causal role or not. And the justification for that was that it is very difficult to assess the causal role, and on the other end, very difficult to imagine that pregnancy may not have played a causal role on the occurrence of suicide. So we followed this recommendation and we modified our system just to be able to, we hope, reliably identify, document, and assess maternal suicide. So, as I previously mentioned, the linkage of birth I'm very sorry, I just realized that this slide is in French, but anyway, I will comment it in English, and sorry for that. So as I previously mentioned, the identification step, the important and very important thing is to have linkage of death and birth registers, as the majority of suicide, as we'll see just after, occur late after pregnancy and delivery, at a time when the obstetrics team do not have any news of the woman. So this is very important. And then at the documentation step, we added a section on suicide specific to this condition, built with psychiatrists. And we added to our pool of assessors psychiatrists, and we have currently 40 of the old territories that go in pair with an obstetrician or a midwife on site to collect information on suicide. Then, final modification, we now have two experts that are psychiatrists within the National Committee, and of course, their expertise is absolutely needed to correctly assess suicides and preventability of suicides. Oh, here it is, sorry. So what is the frequency of maternal suicide in France? So as you see here, before we included all this modification and before we applied this rule promoted by WHO, we only had a very few suicides that were considered as maternal deaths in our system. Since 2013, which is the time when we now have completely applied this rule, as you see, the number of suicides has much increased. And as we see here in the last report, suicide is now suicide and psychiatrist cause, but among this broad category, as you see here, most of the deaths are suicides. So maternal suicide is the leading cause of maternal mortality in France up to 1 year. As you can see here, it represents one maternal death over 6, which means that one maternal suicide occurs every 3 to 4 weeks in France. When we look now not at proportion, but at maternal mortality as ratio per 100,000 live births, you see here the same predominance of a maternal mortality due to suicide with a maternal mortality ratio of 1.9. But you see that if the surveillance was limited to 42 days, then we would have the light blue profile, and of course suicide will appear as a marginal cause. And this is why it is very important to be able to have a reliable and complete identification of maternal death up to 1 year to be able to provide information reliable on maternal suicide. If we look at the evolution of these maternal mortality ratios by cause over the last 12 years, the profile in France has been largely marked by a decrease, statistically significant, in direct causes of maternal death, and this was explained by the very important decrease in maternal mortality due to hemorrhage, which itself was explained by the almost complete disparition of maternal death due to uterine atonia. During the same time, and we only have 2 reports here because, as I explained before that, we really think that we underestimated maternal suicide and our surveillance was not appropriate for this cause of death. Here we have something that could appear as an increase. It's not statistically significant, but of course we'll be very vigilant over the next years to see if this apparently increased trend is confirmed or not. So when we compare this maternal mortality ratio due to suicide to the one reported by other countries, France appears as a little bit lower than other countries, including United Kingdom, Italy, and Netherlands over similar periods. Looking a little bit more at these events and combining together these 6 years of maternal suicide for a number of 80 events. When do these events occur? As you can see here, 90% occur after a delivery. And within this postpartum period, only 1 over 7 occur within the 42 days, and the vast majority of them occur between 42 days and 1 year. Again, stressing the importance of extending the surveillance of maternal death up to 1 year. The median time of occurrence of the suicide is about 4 months postpartum, and this, of course, is a challenge in terms of surveillance, but it also means that that's a period when the woman is often away from the care systems because the postpartum surveillance has finished, and this is very challenging to think of an organization of care that would cover this period, which seems to be very at risk in terms of mental health. The methods for suiciding are very often violent, so with a clear intention to provide death. And interestingly, in a non-marginal proportion of our suicide, 13% here, these deaths occurred in an institution. So when the woman should have been taken by others, and this could be in a psychiatrist hospital, a maternity hospital, or even in prison. So also probably meaning that this institution underestimated the risk of suicide in women. So what are the characteristics, general socio-demographic characteristic of this woman? I've put here in the first column the proportion of each characteristics among maternal suicide, and as a reference, the proportion of the same characteristic among a national sample of women giving birth in France in 2016, which is in the middle of the period for the suicide. So what we see is that maternal suicides, women who died from maternal suicide do not have a specific profile in terms of age. They are less often migrant women, which is very interesting because we know that the prevalence of mental health disorders is higher among migrant women, and we have documentation for that in France. But then it seems that the suicide and the act of suiciding may be less often decided in this woman. Women who suicide have more often social vulnerability. They are more often primiparous women, more often with multiple pregnancy, but the numbers, of course, are very low. And the suicide occur more often in a context of perinatal, intrauterine fetal, or neonatal death. There is a frequent association with drug consumptions, and of course also, and this is known, a frequent association with violence toward women, and we know that those two characteristics are probably very underestimated as we rely on the content of medical files. Very interestingly, is the information about the existence of psychiatry history in this woman. Actually, in 30% of the women, these previous psychiatric conditions before pregnancy was existed and was known by the obstetrical team, but in 3/4 of these cases, there was not organized and formal joint follow-up between the obstetric and the psychiatrist team for these women who had pre-existing psychiatric conditions. So this, of course, opened the door for opportunity for prevention. In 27% of the women, we found by retrospectively gathering information on these women that there were pre-existing psychiatric conditions, but they were not known by the obstetric team. So of course, this also offers, and we'll go back to that just after, to opportunity for prevention. And finally, in a little bit less than half of these women, there were not known pre-existing psychiatric condition, but of course it might mean that this woman did not have such conditions, and but also that there were such conditions, but we cannot find any information of them anywhere. So maybe opportunity for prevention. So this show you the results in terms of preventability of maternal death in France over the last 12 years, sorry. So overall, something like between 50 and 60% of maternal deaths occurring in France are considered probably in red or possibly in blue preventable. And this means that at least one aspect of care, if it had been managed differently, might have prevented the occurrence of the death. And so this evolution is not statistically significant, but what is interesting is that for suicide and psychiatrist causes in general, but we've seen that it's mostly suicide, this proportion is very high. So meaning that there is a large room for improvement. So beyond the numbers, what are the opportunities for prevention that have emerged from the national analysis of maternal suicide in France, and what are the key messages from this system? So there are 4 big sections. So better identification of women at risk, better recognition of first symptoms or alert symptoms, better anticipation in women with pre-existing condition, and better orientation when first symptoms have been identified. So how to better identify risk factors and women at risk? So this first comes from destigmatization of psychiatrist condition within the society in general and among women in particular, so that they can share such history with care providers. And second, train professional, and in particular obstetricians, midwives, but also general practitioner, to search for this history and have tools for asking women about such at-risk vulnerability factors. So women may hesitate to disclose symptoms, and clinicians may feel insufficiently trained to explore psychological vulnerability. Second, improved detection of warning signs. So screening should not occur only once. It should be repeated throughout pregnancy and the postpartum period. And this can be done through simple questions, but also through self-administered questionnaires. And widely known one is the EPDS, Edinburgh Postpartum Depression Scale, which can help open conversations with women about distress, depression, anxiety, or intrusive thoughts. So different things have been implemented in France to increase and to work on this prevention opportunities. So there have been information campaigns through national media. There are flyers provided in maternity hospitals and app available for women and their family to talk about maternal mental health and try to overcome taboo about it. in terms of training of the professional, now maternal mental health has been included in initial and continuous training of professional in obstetrics, and it's a theme that is repeatedly covered by scientific congress, and also more and more maternity units are routinely implementing a screening in postpartum with the EPDs. Another aspects of prevention that emerge from the national study of maternal death is better anticipation for women who have known psychiatric disorders. So this requires joint obstetric psychiatric care pathways, preconceptional counseling when possible, clear communication tools between providers, and involvement of primary care. And this can happen with including this in the continuous training of professional. And we can also mention that some hospitals have initiated a specific care pathway for those women with very interesting results and evaluation that are ongoing and may be important to share in the following years. Finally, and most importantly, we have to improve referral and system orientation and organization, because if such a system is not in place, then we can understand that care professionals may be reluctant to increase identification of women at risk and women with symptoms if they don't know how to correctly refer this woman thereafter. So the perinatal mental health offer is still very insufficient in France and in many regions, but there are some improvements. There is a new perinatal psychiatry specialty that exists since a couple of years, and the new psychiatrists with such specialty will be in charge of patients in a couple of years. And overall, there have been a psychiatry plan in France with increased number of trained psychiatrists. So overall, maternal suicide must be recognized as a key indicator of maternal mental health. Thanks to our confidential inquiry capacity to link national data sets, maternal suicides are now reliably identified for the first time in France. And their profile constitutes a strong alarm signal and should guide national action plans, as it appears at the first cause of maternal mortality currently, with a large proportion of preventable deaths and with clear identification of areas for improvements. So if improvement is possible, and it is essential. And I would like to finish by saying that if it is very important to have such a study of maternal suicide, it is also important to complete this analysis by studies focusing on morbid events, women with postpartum depression, with PTSD, with bipolar disorders, to understand and document all the morbidity continuum, not only the fatal events. I would like to finish by analyzing the contribution of all the people that are involved in this system, and all reports and materials are freely available on our website, and feel free to contact me for any further information. Thank you very much, and have a wonderful conference.